I want to welcome everyone. I am Dr. Eli Putterman. If you've been on this call before, you're familiar with who I am, but just for those who don't know me, I am an associate professor in the School of Kinesiology at UBC, and I am zooming in from the ancestral, the unceded, the stolen and traditional lands of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and Tsleil-Waututh nations. Many of you are joining us from a different territory, and if you are interested in learning more about the territory that you live and work on, you can visit www.native-land.ca. I will post that into the chat box shortly. The Dialogue on Aging public presentation series is sponsored by UBC's Edwin Azich Leong Center for Healthy Aging and Providence Healthcare to provide our public presentations. The series features distinguished speakers who present on broad topics in current aging research to share findings with the community. Now, I'm very excited to introduce our speaker today of today's presentation, Dr. Teresa Liu-Ambrose. Dr. Ambrose is a colleague of mine. She's a friend. She's a confidant. So it's really a thrill to hear her speak today. Dr. Teresa Liu-Ambrose is a professor and is a physical therapist and a Tier 1 Canada Research Chair at the University of British Columbia in the Department of Physical Therapy. She directs the Aging, Mobility, and Cognitive Health Laboratory, as well as the Vancouver General Hospital's Falls Prevention Clinic. She's also co-director of the Center for Aging Smart at the Vancouver Coastal Health, also known as Center for Hip Health and Mobility. Her research focuses on understanding the role of exercise in promoting cognitive and mobility outcomes in older adults. And we were a bit delayed, so I'm just going to let her launch into it. But Teresa, it's really a pleasure to have you here. Thank you so much for joining our public speaker series today.
Yeah, and thank you, Eli, for the invitation. And to everybody, thanks for your patience. And it's really a pleasure to be with all of you today. So I thought what we would do today is for me to share the research we do here at UBC within the area of promoting cognitive and brain health in individuals who are at risk for cognitive impairment and dementia. And so, as Eli mentioned, I'm a professor within the Department of Physical Therapy. And I think being a physical therapist, I really have a strong interest in the role of exercise in promoting health outcomes. And just simply over the course of my own research program, I've really narrowed in on cognitive health. And so in terms of today, I thought I'd provide a very brief context or a background to the research that we do here, and then highlight a few studies that we have completed or just completed and sort of the future directions of my research program. So first and foremost, I'm sure all of you do recognize that exercise is good for us and that it has many health benefits. And I also am sure if you even listen to the radio or even just chatting socially, that you've also heard that exercise is really good for brain health. And so that, you know, in terms of the popular media, we do hear a lot about exercising to promote brain health and to promote brain function. And it's not just about media or sort of coffee talk per se. There is strong evidence to support that. So first and foremost, in 2019, the World Health Organization did publish guidelines on risk reduction of cognitive decline and dementia. And so within this document, they basically talked about different strategies and evidence by which an individual could reduce their own chance of developing cognitive impairment in aging. Now, what's interesting when it comes to physical activity is that they do recommend it, but only sort of with a strong recommendation to individuals with normal cognition. So that in essence, they're saying physical activity would be great for individuals who do not have any cognitive issues at hand, and that they want to reduce their risk of cognitive decline over time. Now, for individuals who already have some degree of cognitive impairment, such as individuals with mild cognitive impairment, the recommendation when it came to physical activity actually was conditional, meaning that based on the evidence, the World Health Organization actually felt that the evidence was low, and therefore the strength of their recommendation was placed at conditional. And so today, what I'd like to do is essentially share what we have done within the area of physical activity and individuals with mild cognitive impairment. And in doing that, I first just want to define what we mean by mild cognitive impairment. So mild cognitive impairment is a state, and it's not in the state of dementia whereby an individual has um, lost the capacity to function independently. Individuals with mild cognitive impairment, they actually are still fairly functional. Majority of them, if not all of them, are still living at home if that's their choice. What's really interesting about mild cognitive impairment is that it can be transient. So depending on, the time of the year or which year, and the person's being assessed, they may be deemed to have mild cognitive impairment, and a year later on reassessment be deemed to be normal or potentially have progressed further onwards. So what's key about mild cognitive impairment is that reversion is possible. And as such, because we know individuals with mild cognitive impairment also have a greater risk of developing dementia, it's been viewed that individuals with MCI is a target population to intervene to reduce the risk of dementia. And I also want to highlight that when it comes to mild cognitive impairment, we're not just referring to individuals potentially who will develop Alzheimer's disease, but also other forms of dementia. So mild cognitive impairment is not unique to Alzheimer's disease, and it's really a state that, is prior to developing dementia, to having dementia. In terms of how we define mild cognitive impairment, often it's based on a few key criteria, including subjective complaints. So we might, in interviewing individuals, someone may say, I am quite worried about my memory as of late, or even my attention. And when we assess them with standard testing, there would be some evidence of objective deficits. However, as I mentioned, these individuals are still functionally capable, meaning, again, they are living in their own homes, still managing their diet, dressing appropriately, and also being able to deal with their finances. Now, I also want to define or talk about dementia. So dementia, first and foremost, is an umbrella term. Dementia in itself is not Alzheimer's disease. Alzheimer's disease is a form of dementia, and it is the most common type of dementia worldwide. But dementia is an umbrella term. And when it comes to the primary causes or major causes of dementia, again, I appreciate majority of not everybody recognizes Alzheimer's disease, but perhaps less recognized is the vascular version, which is vascular dementia or vascular cognitive impairment. So both Alzheimer's disease and vascular dementia are the two most common types or common causes of dementia. And what you can see here is that in terms of commonality, Alzheimer's disease essentially accounts for about 60 to 70% of all cases of dementia, while vascular dementia is about 10 to 20%. However, I do want to emphasize that we do recognize that the estimate of how common vascular dementia is probably underreported, because in some ways it's a bit hard to track or detect, because some of the changes are actually quite difficult to determine. What's quite different between Alzheimer's disease and vascular dementia is that Alzheimer's disease is often characterized by what we call amyloid or tangles within the brain, while vascular dementia is really characterized by disease or injury to the blood vessels leading to the brain and also feeding the brain. Now, in this figure, I'm obviously showing these two types of dementia as quite unique to each other, but in reality, we actually know there's a huge interaction, meaning that individuals with vascular risk factors are not only at risk for developing vascular dementia, but also for Alzheimer's disease. And conversely, individuals with Alzheimer's disease pathology also have increased risk of developing um, uh, impairment within the blood vessels leading to the brain or feeding the brain. And so in essence, the saying of healthy heart, healthy brain really is true when it comes to preventing or reducing dementia risk. Now, for my lab, we do focus a lot on vascular dementia, or what we call nowadays vascular cognitive impairment, because when you look at the risk factors, they're highly modifiable. So anything related to your cardiovascular health can potentially impact your risk of developing vascular cognitive impairment. And when we talk about disease or injury to the blood vessels, I just want to provide two key examples. So a very common disease that causes vascular dementia is cerebral small vessel disease. And this is when the small vessels that, again, lead into and feed your brain becomes compromised. And often this pathology is actually quite silent, but extremely common. So on neuroimaging, whereby we can detect cerebral small vessel disease quite easily, by the time we're scanning individuals who are 65 years old, probably about 90% of them will have evidence of cerebral small vessel disease. A clear example of injury that can lead to vascular dementia is head trauma or a stroke. And in our research, we look at both cerebral small vessel disease as well as stroke. And so just a bit of expansion on cerebral small vessel disease, because again, I really want to highlight how we can actually modify our risk for developing vascular dementia. So risk factors for developing cerebral small vessel disease include age, which is not modifiable, but other key risk factors include high blood pressure, type 2 diabetes, and poor lipid profiles. And these conditions do increase in frequency as we age. And with these risk factors, what can happen is that, again, the small vessels that feed your brain become compromised. They might get plugged up, or they might get have a bit of plaque in them and impedes the blood flow. And what happens is that essentially bits of your brain do not receive sufficient blood flow or nutrients. And on neuroimaging, what we can see is these white, bright intensities, what we call white matter intensities. And these intensities really indicate some degree of brain cell death due to the cerebral small vessel disease. Or we could see larger lesions such as lacunes, which appear more black on neuroimaging and indicates essentially neuronal death with fluid filled within that. What's really notable and what I would like to emphasize is that with cerebral small vessel disease, they're often what we call clinically silent, meaning that their symptomology or the consequences of them are not obvious. And it's only over time that we understand the negative effects of cerebral small vessel disease on the individual. And what we do know from large population studies is that cerebral small vessel disease over time increases one's risk of developing a stroke, having dementia, as well as having limited mobility. And so with our research program, again, we're very much interested in how exercise can modify the risk of developing cognitive impairment among individuals. And so just going back to this slide again, if you look at the key risk factors for cerebral small vessel disease, I hope you would agree with me that when it comes to hypertension, high cholesterol, or type 2 diabetes, these are chronic conditions that are highly modifiable through diet and also through exercise. And so What we did back in 2016 was actually to conduct a small exercise trial to look at the effect of aerobic exercise on cognitive function in people living with cerebral small vessel disease. And you would think there would have been a study like this already, because in truth is when we were doing this study, there's already been a number of larger studies looking at drug therapy in individuals living with cerebral small vessel disease to see that, if you could give people drugs that potentially could lower their blood pressure or lower their lipid profiles, could that then result in better cognitive function? Um, and yet, no study at that point in time actually looked at exercise as a potential strategy. And so that's what we did. So we essentially recruited 71 individuals with evidence of cerebral small vessel disease on neuroimaging, as well as having mild cognitive impairment. And we essentially randomized half of them to a moderate intensity aerobic exercise, which really was like a brisk walking program outdoors. And the other half got randomized to a education group whereby they received education on healthy aging, healthy lifestyles, etc. We intervened for 6 months and we looked at people's cognition before and after, and also acquired neuroimaging. And then we also followed them up for additional 6 months, basically to see if there's residual benefits of exercise. And so again, this was the two potential groups that people will be randomized to. But as I summarized already, one group received aerobic training and the other group received education. And this is just a picture or a photo from one of the exercise classes. And as I highlighted, it was an outdoor program. That's one of the advantages of being in Vancouver. Our weather is pretty mild throughout the year. And so we were able to conduct the entire 6-month intervention outdoors through rain or on sunny days. But I also want to really highlight here is that in terms of our participants, there was a wide range. So in the background, you see an older adult who essentially is getting around with a mobility aid. And then we have also then a gentleman in a Hawaiian shirt who looks much more mobile and has pretty good balance such that they don't need any additional aid in doing this static stretch. So just to highlight that, we were not working with a overly robust group and that there was like a diversity in physical function across our participants. And so what did we find? So we found that after 6 months, that aerobic training group did actually significantly improve memory as compared to the education group. And what I also like to highlight is that we were able to determine that the degree of improvement in memory actually was the same or greater as compared to prior trials of drug therapy in the same population. So to me, that's actually pretty impressive, right? Because I think for the majority of us, we often think that a drug therapy would be more potent than something like exercise. But we're really recognizing that exercise can be particularly potent in bringing about health benefits, including cognitive improvements. We also saw, and probably not surprisingly, a reduction in blood pressure, specifically in diastolic blood pressure, and there's a significant reduction by 5 millimeters mercury. And I just want to highlight that this degree of change may translate to protection against future stroke. And remember, for this particular study group, these are individuals at risk of a future stroke because they already have cerebral small vessel disease. Now, in our lab, we're also really interested in understanding who benefits and who may not. So like in most things, even as, with drug therapy, we know some people seem to react very well to certain drugs while others do not. And when it comes to exercise, what we do recognize that some people seem to benefit more so than others. And so what we also found within this trial that when it came to executive functions, which is a different type of cognitive process than memory, it's more related to your ability to multitask and to plan. We found that there was a benefit of the aerobic exercise on executive functions, but for females and not as compared with males. And so what you see here in this slide, essentially, if I can just quickly show everybody, is that so here a lower score indicates greater improvement. The light gray indicates individuals who are in the aerobically trained group, and then the solid black indicates the education group. And what we can see here is that among females, those who receive the aerobic training group clearly benefited as compared to the females in the control group. However, for males, we actually don't see that trend. We actually see not an improvement for males who received aerobic training when it comes to executive functions. And this isn't so much a random observation. This sex difference has been shown previously in other studies, and we continue to see that in our own studies as well, in other studies that we've done as well. Now, one of the explanations as to why females may have benefited more so as compared with males, it could be possibly be related to the effect of aerobic exercise on what we call the brain-derived neurotrophic factor. So when it comes to how exercise, particularly aerobic training, may improve cognition, one of the strongest theories is that it increases growth factors, specifically the brain-derived neurotrophic factor. And what we found here in our study is that when it came to BDNF, so we did measure blood before and after the study, what we found is that in the aerobic training group, females increased their levels of BDNF, which is often viewed as good, while males did not. And perhaps this is one of the reasons why we are seeing sex differences in the effect of aerobic exercise on cognition. Now, our group is also very much interested in looking at types of exercise. So not just exercise as a whole, but really, again, gaining evidence so that we can be much more precise in how we prescribe exercise to an individual so they can benefit the most for themselves. And so to date, when you are looking at the evidence for exercise and cognition, the majority of studies have focused on aerobic training, so running, jogging, cycling, etc. And less has been done on resistance training, which is, again, exercises focused on increasing muscle strength or muscle mass, so usually using weights or machinery to make those gains. And so we also conducted, most recently, looking at the effect of resistance training in cerebral small vessel disease. And for this particular study, we had 91 individuals. And again, they were randomized to one of two groups, one half being in the resistance training group and the other half in what we call a balance and tone group, whereby they're still exercising, but they're just not engaging in progressive resistance training. For this particular trial, they were trained for 12 months, and we measured them at baseline, 6 and 12 months. And again, very positive results, such that we found that for the resistance training group, they did improve global cognition among individuals with cerebral small vessel disease as compared with a balance and tone group. And again, we saw the preference for females, whereby females benefited more so as compared with the males. What's also really interesting when it comes to resistance training is that we're also been showing, so we've been now shown it across 2 studies now, whereby resistance training seems to have a potent effect on the actual disease course. So what we have found in this particular study, but also in a prior study, is that 12 months of twice a week of resistance training could actually reduce the disease progression of white matter hyperintensities. So what we do know is that once someone has cerebral small vessel disease, and then again on your imaging, they show up as these white, hyper-intense images, or here I'm showing them in blue, is that they would only increase in size. So what you see here, potentially over time, oops, sorry, let me just get the lesion. So what you see here in itself is a lesion. Hold on. Here we go. So these are what we would call the lesions due to cerebral small vessel disease. And we actually know from population studies that they would only increase in size. So if I scan somebody's brain over time, these blue sections would only increase in volume. And over time, that's when you'll see more progressive deficits in cognitive function and potentially also in their mobility, and as well as potentially an increased risk in stroke. And what we are finding is that with resistance training, we can actually see like a maintenance of that disease such that it's not progressing as it normally would in the absence of training. And again, I would highlight that that's pretty impactful, given that we often think exercise is good in promoting health, but not necessarily in modifying disease progression. And so the next a study I want to introduce is actually now looking at the role of exercise in individuals who have suffered a stroke. Now, there's been many trials of exercise in people with stroke, but the majority of them, probably over 90% of them, focus on physical function. So how does exercise restore physical function in someone who have suffered a stroke? And that's obviously really important because after a stroke, people do have significant physical impairments. Usually, the loss of, the use of their arm or their leg or their balance really poor. So very, very important for sure. But at the same time, we also do know that once someone has had a stroke, they have about 50% increase, or they double their risk of developing dementia. And so preserving or promoting cognitive health in people after a stroke is also really important. And again, to my own surprise, when we first were thinking about developing a study to look at exercise in promoting cognition in people who have suffered a stroke, I was honestly flabbergasted by the lack of research that actually have been done. And so for this particular trial, we recruited 120 individuals who have suffered a stroke within the prior 12 months. So they were deemed to be stable post-stroke. And what we did is we randomized them to one of three groups, either twice a week of exercise or twice a week what we call mastermind, and I'll explain that a little bit more in the subsequent slides, as well as or to a twice a week balance and tone group. The intervention was for 6 months, and then we followed them up again for another 6 months to look at potential residual effects. So for the exercise program, in this particular study, it was multimodal, meaning that we included a number or different types of exercise training, such as gait retraining, balance retraining, coordination, functional strength, and also functional strength using strategies such as body weight. Progressive resistance training is much harder to deliver for individuals who have suffered a stroke due to spasms, etc. So in terms of strength training or increasing their strength is usually done through functional movements and using their body weight. In terms of the mastermind, it really was a group we designed based on the theory of enrichment. So our approach to this study was we're interested in promoting cognitive function in people who have suffered a stroke, but we also recognize that for people that after a stroke, people do have often have physical limitations. And so perhaps their capacity to engage in exercise may be a bit limited. And so we were also wanting to look at alternative ways by which we could promote cognition in people who have suffered a stroke. So we developed this cognitive and social enrichment group whereby they engaged in cognitive training and lots of social but cognitively engagement activities such as improv, as well as puzzles, but again, done in pairs. So you're having this interaction with a cognitive load on top of the social activity. For the active control group, they were receiving balance and tone exercises, which can provide benefits for them, but potentially not for their cognition. And then once per month, we swapped out the back classes with an education seminar. And the results of the study was published in JAMA Network. And what we found really was quite interesting was one, the mastermind had no effect or not a significant effect on cognition, but exercise did. But notably, what we found is that essentially, if you look at our cognitive scores at baseline or at steady entry, our participants were in a state of what we call impaired cognitive function based on the scores. And over time, with the exercise intervention, people actually were shifting to what we would call a more normal state of cognition based on the standards published for that cognitive test. And so then moving forward is that, with research, what's really always exciting about it is that the evidence is always changing. And so, lots of research has occurred since 2019, and when the WHO published their report. And really here, I'm just giving a few examples, but the takeaway is that now when it comes to, how to best promote cognition for people living with mild cognitive impairment, there is the notion or evidence that perhaps mind-body exercise may be particularly beneficial. And that refers to exercise modes such as yoga and Tai Chi, whereby it's not just the physical movement that's occurring, but also there's some type of cognitive component related to the physical activity. And with that in mind, our lab, and especially driven by PhD trainee, over time, we've been quite interested in looking at, the environment by which we exercise in. So over the last few years, we've been looking more at the intersection between exercise, cognitive health, and nature. And so here, I'm going to end the presentation with one last study that's been really the brain, sort of the sort of the product of Matt Noseworthy, who really had a passion for understanding the potential benefit of engaging in exercise while being in green space. And so for his PhD, he conducted a small randomized controlled trial, essentially looking at the effect of aerobic exercise done within an outdoor natural environment versus aerobic exercise done indoors, such as in gym, on cognitive function among individuals with mild cognitive impairment. And as some of you, or maybe all of you know, there's been a lot of good evidence on the benefits of green exposure in terms of people's mood or even health outcomes such as hospitalization, etc. Like when I go through the literature myself, I'm actually quite surprised and impressed by the potential benefit of just being kind of immersed in a green space. So in this particular study, what we're looking at is whether exercising in the green space could potentially magnify the effect of exercise on cognitive function. And so for this particular study that we call SAGE, we managed to recruit 72 individuals, all had mild cognitive impairment as defined by the Montreal Cognitive Assessment test. And it was a smaller trial for 12 weeks, whereby the assessors were blinded, so they didn't know what group individuals were in. And essentially, again, we had the randomization where people either were randomized to outdoor exercise program, which really was a brisk walking program down in the endowment lands near UBC, or they engaged in the same moderate intensity aerobic exercise indoors in our research facility gym, either exercising on the treadmill or on a stationary bike. Everybody came 3 times per week. Each session was 1 hour, and we did put on heart rate monitors, etc., to make sure that they were always exercising at the moderate intensity, which be akin to you could still have a conversation, but it's with great effort. We collected a number of cognitive outcomes, but just to say that we focused on both memory as well as executive functions. And here just are some characteristics. So of the individuals we recruited, they were about, 73, 74 years of age. And I also want to highlight that they were all had evidence of mild cognitive impairment based on the MoCA. And then what do we find? So I know this is like a really busy table, but in essence, what we found is that individuals who got to exercise outdoors actually did better than people who exercised indoors, specifically when it came to executive functions as measured by 2 different computerized cognitive tests. The outdoor group did significantly better than the indoor group. And what we also did find, which I don't show here on this particular slide, is that we also found that the individuals who exercise outdoors actually also increased their functional fitness more so as compared to the indoor group, even though we did go and check on the heart rate monitors and checked on the intensity. Both groups actually managed to exercise at the appropriate intensity. So it would appear that there is something potentially about exercising outdoors that might be more beneficial as compared to exercising indoors. And so that's really the conclusion at this point, is that, doing exercise outdoors may actually benefit cognitive function more so than if you were exercising indoors. And I would say, I also a big fan of green space, so I often take my yellow Labrador out to the forest, and I can, and even though I'm not really doing the experiment for myself, I do know that often after a run in the woods, I feel much better as compared to potentially going to the gym and running on the treadmill. So then in terms of future directions, well, first, I just want to really highlight the impact of our research, or what we have collectively done at UBC. So first and foremost, over the last 15 years that I've been in my position, I've seen a huge shift in how people view exercise when it comes to brain health. When I first started in this area, when you speak to neurologists, etc., there was definitely a lot more reservation as to how beneficial exercise could be for someone's cognitive health. And I think now, 15 years later, that there's been a huge shift in how people perceive the role of exercise, not only in healthy aging, but in healthy cognitive aging. I think where our work has really made a difference is that broadening the field of or broadening the perspective of what we think would be helpful within the context of type of exercise. So again, the majority of time we tend to default to aerobic exercise, even though the evidence would suggest other types of exercise, including resistance training, could be highly beneficial, not only again for cognitive function, but actually modifying existing disease. And so this New Yorker cartoon actually came out soon after one of our papers was published. And basically, what you see is like an individual with a fairly big head. And the caption says, "I've been working out for 6 months, but all my gains have been in cognitive function." Our research has also been helpful in shaping practice guidelines when it comes to how to best potentially manage individuals living with mild cognitive impairment. And so for this particular report that was published by the American Academy of Neurology for the first time, and this was published at the end of 2018, early 2019, for the first time, the Academy included the recommendation of exercise. And again, I already highlighted in 2019, the WHO guideline in itself recognized physical activity as a strategy. However, again, at that point in time, for those with normal cognition. But nevertheless, the fact that it included physical activity as a strategy, I think is a huge win as compared to 15 to 20 years ago. And then moving forward, our group, but I think also globally, many groups, what we're working towards is increasing precision. So we do have good evidence to show that exercise is beneficial, but then it's always about how to refine it. So really kind of being able to deliver on exercise as medicine. And so to do that, we need to really know the who, the what, who, and how, such as what type of exercise, for whom. So we talked about some sex differences, but potentially, how people respond to exercise could also be dependent on their genotype. And then the how. So how does exercise bring about its benefits? So a lot of what we know is largely based on animal models. And in part is because it's hard to sometimes really directly assess biological mechanisms in vivo or within a human or within people. But we're trying to with different strategies such as state-of-art neuroimaging and using novel fluid biomarkers moving forward. And hopefully by knowing more about the what, who, and how, we can refine the recommendations so that each individual reaps the most benefit from exercise. And so with that, that's the sort of what I'd like to share today. And before I close, I just want to say thank you for being here. And also, I just want to acknowledge my lab. Everything I've shared today is because of them, as well as our participants who really are very generous in donating their time to us so that we can do the research that hopefully inform practice moving forward. Thank you.
Fantastic. I'll start off with a question until I start seeing some questions in the chat. For the study with outdoor exercise versus indoor exercise, I'm really curious, is there something special about nature other than the beauty of it and being in a calm state, or maybe it sets in a calm, is there something else about terrain, about the difficulty with the terrain
Yeah.
that you're thinking is part of it?
Yeah, no, I do think so. I do think it goes back to the mind-body concept,
Mhm.
such that, so first and foremost, when it came to the routes, they were all mapped out. And we tried to make
Mm.
sure they were not too challenging in terms of navigating. But the end of the day is still trails, right?
Hmm.
And so I do think you need to be much more aware of what you're doing than if you're doing a brisk walk or a jog on the treadmill. So there's still more of a cognitive loading.
Someone online, and I'm not sure what slide it's talking about. There's something about education that you were talking about, and were you talking about specifically just education on dementia that people need that, or were you speaking more about like taking courses that challenge the person's thinking, learning new languages? Just
Sure.
kind of, yeah, if you can speak to some of that.
Yeah. So in terms of the education we provide within our research study, it's more about education that would potentially help them act on behaviors that would be helpful for their health. So that we would have nutrition, like a dietitian come in to talk about diet, specific recipes. So sometimes we would actually have an active cooking class where we would make omega rich salad or muffin. And then we would have sessions on sleep, how to get a better sleep, why sleep is important for health. We also had sessions on goal setting. So whatever your goals are, we talked about goal setting as being a critical skill set in achieving, whatever you wish to achieve. So it wasn't so much about um, education, like learning a new topic per se, but more tips about how to age well, I suppose.
Fantastic. Thank you. Another person asked a question about what was the intensity of the walking exercise that you studied.
Sure.
And then I have a follow-up question to ask you after.
Sure. Yeah. So we've been primarily focusing on moderate intensity. So um, that's essentially like a easy way of describing it is that if you were going for a jog or run, it's at a pace whereby you can still carry a conversation, but it's somewhat of a challenge to do so.
Right. Can you speak to the because you had studies on outdoor versus indoor, you had studies on resistance training, aerobic exercise. How much do you think the import or can you talk a bit of like variety and the importance of variety for the audience within those, like as a recommendation
Sure.
or
Yeah.
yeah,
Yeah, so I think what you're asking is like, why not just default to multimodal? Like, so which
yeah,
is like, we would include a class, I think similar to the stroke study where we had a bit of everything. Is that what
right.
you're asking? Yeah.
Yeah, yeah.
Yeah. And so certainly there's been, I think that's where a lot of the research has shifted is to multimodal. And as a clinician, I would agree all types of exercise potentially is beneficial, right? The reason we've been segregating different classes, like a specific type per group, is because we're trying to better understand whether they are potential differences in the effect of a certain type of exercise on cognitive outcomes.
Hmm.
Because there are some suggestions that there might be differential effects. And so this comes down to the goal of precision, whereby maybe in the future, if we know you have deficits in memory, then maybe it might be more about aerobic exercise as compared to resistance training, where right now seems to be more banking on executive functions.
Right. Fantastic. Thank you. I'll just keep on with some of the questions. So, second question that was asked by an individual, and I'm going to make some assumptions of
Okay.
what they mean. So they wrote, if you don't exercise, do you lose your cognitive gains? So I'm assuming, let's say you start exercising, but then you stop.
Yeah.
Do you go back to like baseline?
Yeah, no, that's a great question. And I think, or what we have found is yes. So as I did indicate, for at least a few of our studies, we did follow-ups. I didn't always present the results of those, but in essence, at the follow-up, when people did not keep up with their activity, their gains were no longer evident.
Right. Right.
Yeah,
I mean, that makes sense, right?
yeah,
To get the gains, you have to move your body,
yeah.
right?
And I think that's true probably for
Yeah.
most things. Yeah,
Yeah, I see it in the mental health work that I've presented before. It's like
yeah.
similar. If you don't exercise, you lose those gains. So that makes sense. Another person asked, can mind-body exercise be the focus of exercise, or does it need to be complemented by aerobic exercise? So um, I'm not sure. I'm assuming that when it's mind-body exercise, there is some aerobic, but maybe
Oh,
I'm
yeah.
confused. Yeah,
Yeah,
go ahead.
so mind body doesn't, so I guess if I understand the question correctly, so mind body exercise does not have to be aerobic exercise. So a really like two key examples of what most of us agree as mind body exercise would be Tai Chi and then
Hmm.
potentially yoga. And they're mind body because, again, especially with Tai Chi, it's specific forms, it's a specific pattern of movement. So you're learning as you're going, and it's not aerobic at all. At best,
Hmm.
not at best, it definitely is more balanced if I had to categorically classify it with coordination and some functional movements like functional strength, because there's a lot of squatting, lunges, um, and single stepping, right? So there's no aerobic component, but that's a classic mind body example.
Hmm. And so can that be completed on its own? And That's
Yes,
okay?
yeah.
Yeah. Okay,
Yeah,
great.
so there's been actually really good evidence for Tai Chi. It's been shown to be beneficial. Oh, so we haven't done these studies, but the literature would suggest it does have benefits for cognition, but also significantly reduce falls.
No, but
Yeah,
yeah, that makes sense. Yeah, that
yeah.
makes complete sense. I'll keep going down the list if that's
Okay.
okay with you. Can you assume that some of these exercise results can be applied to other forms of dementia in the early stages?
Yeah, I do. I mean, so, and I think this is in part, especially for thinking about Alzheimer's disease and vascular dementia or vascular cognitive impairment. Again, we tend to bin them, but there is so much interaction between the two of them. In most cases, there's probably a bit of both in individuals. And so at the heart of it all is that when your cardiovascular profile is not great, you are at increased risk for both types,
Right.
right?
Okay.
And so, and this is where we know exercise has very potent effects.
There are some people who have asked some questions around some options for those with mobility limitations, and
Mhm.
this comes from a few different listeners right now.
Yeah, and thanks for that because again, my other hat is about falls, and so limited mobility is something we're very cognizant about, and that's actually one of the reasons we went into the area of resistance training, because that is a form of training that can be done and modify for individuals with limited mobility. So resistance training is a great option. And I
Hmm.
also want to highlight something like Tai Chi is a great option for people with limited mobility because, again, we're not asking people to go on a brisk walk.
Right. And there's also, if I'm not mistaken, a lot of videos online for uh, chair exercises, right? While you're
Absolutely.
sitting in a chair, you can like different types of things you can do with small weights or no weights, but
Yeah.
different kind of exercises that people can do as well.
And I
Um,
also want to highlight, and I use the term functional movements, but depending on the individual, literally a sit to a stand and back down can be deemed a strength training exercise for that individual. Like for many of the people we see in the falls clinic, I would categorically call that a strength training for them, right?
right, right, yeah,
Because, so it kind of depends on your baseline. But for people with limited mobility, there certainly are options.
hmm
Again, seated exercise is great. With weights, the key principles I would say is that what we know to help improve outcomes, whether it's falls or cognition, progression seems to be key. So where you start today, and if you're diligent with it, you do want to be mindful in making sure you progress over time.
right, right. And starting off like, I think about, raising a child. You always want to nudge them or kind of
Yeah,
challenge them just above where they're able to
exactly.
do
Yeah,
in order to like edge that way. And I think that's one of the things that I hear you saying is like go a little bit more challenging than what you can
over
do so that
time.
you're
Yeah,
you're always progressing. That's
yeah,
great.
yeah.
Um, I'll ask a couple of more of the questions that are here. So we heard differences between males and females in cognitive function growth, but what about the differences in age groups? I'm a male aged 80, but maybe females aged 75 showed more growth. So in terms of, I'm assuming we're talking about benefits. Are the benefits maybe different across the ages as well?
Yeah, so right now, if there's age differences and sex differences, again, there's still more research that needs to be done. So within our group and a few other groups we know for older adults, so I'll broadly define that as 65 and older, the majority of the evidence is suggesting females benefit more so.
Mm,
When it comes to the midlife, so the younger than 65, this is where we tend to see a little bit of not discrepancy, but potentially the reverse, whereby it seems that males may benefit more so.
oh, interesting.
Yeah.
Is there
Now,
reasons for that? Or
is there a reason for that?
yeah, yeah.
Yeah, no, there's been a lot of discussion as to why that might be. One could be like the shifting from males versus females as we go from midlife to older age, might be due to the fact that when females go through menopause, etc., they potentially are more vulnerable for
Mm,
cognitive impairment because of the significant reduction in estrogen, and estrogen is very great for the brain, female brain.
mhm.
And so in many ways is that females may benefit more because we have much more room to benefit now.
Right. Thank you. There are two more questions. Do you have time for a couple of more questions? Is that okay? Or
Yeah, yeah.
yeah. Okay. So I'll ask you one more, well, at least one of them. So, can cognitive benefits be achieved by walking outdoors in a green setting and a city setting? Um, so is the outdoor benefits, do you think they're limited to, I think that's a great question. Do you think they're limited to just nature walks, or can sidewalk walk also
Yeah.
benefit?
Well, I would say I would first say I think any walking that you can do consistently would be beneficial than no walking. So, you know, activity, like to reap the benefits, you first have to engage in the activity. So if it's more convenient for you to engage in walking in sidewalks versus having to get into a car and drive 20 minutes to the woods, and that may be the reason you don't end up getting a walk, then obviously do the walk around the sidewalks. Um, we haven't, I don't know of any good research that would indicate there might be a huge difference. I think where the factor might be is about whether the pollution is bad, because there
Right.
is some
Yeah.
evidence to suggest that more urban cities, because of the pollution, that in itself could be bad for cognitive health over time.
Right. Right. Oh, that's interesting. Yeah. And also where you live in those urban
Yeah,
centers, right?
yeah,
Where the flow of the air is.
correct.
And yeah, that's interesting. And then the final question that I see on here, and then I will wrap this up. Uh, did you measure differences in groups such as Parkinson's disease with other groups? Have you looked across different? Uh, I think that's what they're asking about. Yeah.
Yes, I think they're asking whether we included people with various types of neurological conditions.
Yeah. Yeah.
And so just to say, within our studies, we tend to recruit um, more similar people than not. So, for our trials, if it was looking at exercise and stroke, then everybody would have had a history of stroke.
Hmm.
Um, and so we don't, at this point, within like an exercise trial, we don't have the capacity to look at the response based on the pathology. That
Right.
would require a pretty big trial.
Okay. Fantastic.
Yeah.
Um, okay, so Teresa, I want to thank you. I always love listening to you, and I don't think you know this, but before I even started my job at UBC, you gave a talk at the library downtown in 2013, I think, or 14.
Oh, okay.
And I came to the library and I was like just blown away by you, and it thrilled me that I knew I was starting my job a year later at UBC, that I was going to be able to meet you. So this is like a thrill to hear you speak again, and I always love hearing you speak. Bye, thank you. Thank
Thank
you.
you.